आपण आता कार्यक्रम चालू करूया. आजच्या आपल्या वक्त्यांची ओळख करून देतो काही कारणच नाहीये, कारण मागच्या वेळेला शशी डोगळेकरांनी त्यांची चांगल्यापैकी माहिती करून दिली होती. मी फक्त एवढंच म्हणेन की आपण बरेच वेळा अशी माणसं बघतो की त्यांच्याकडे ज्ञान खूप असतं आणि ते ज्ञान दुसऱ्यापर्यंत पोहोचवायची जबरदस्ती इच्छा, शक्ती, तयारी सगळी असते. अशा लोकांच्यापैकी डॉक्टर अशोक वार्देकर आहेत. म्हणजे आपला जो फोरम आहे, म्हणजे इथले सिनियर्स फोरम, वी आर रिअली फॉर्च्युनेट टू हॅव ए पर्सन ऑफ लाईक डॉक्टर अशोक वार्देकर, की ज्यांच्यामुळे आपल्याला अनेक प्रकारची माहिती अगदी सखोलपणे मिळू शकते. तर मागचा आपला जो विषय होता की हार्ट हेल्थ फॉर सिनियर्स, त्यातला आता हा दुसरा भाग आपण चालू करतोय आणि त्याची सगळी माहिती आता डॉक्टर वार्देकर आपल्याला देतीलच. आणि असं करायचंय की वार्देकरांचं प्रेझेंटेशन झालं की त्यानंतर मग साहजिकच आपण नेहमीप्रमाणे प्रश्नोत्तरांच्या करता आपण फोरम प्लॅटफॉर्म उघडा करूया. त्यावेळेला फक्त असं करा की तुम्ही हात वर करायच्या ऐवजी तुम्ही खाली आपल्याकडे रिॲक्शन म्हणून एक हे असतं, ऑप्शन असतो, त्याच्यामध्ये हात असा दाखवलेला आहे, तो फक्त क्लिक करा. म्हणजे तुमचा हात वरती झालेला आहे की तुम्हाला काहीतरी प्रश्न विचारायचा आहे हे मीना दातेकर समजेल. आणि मग जर समजा कोणाचा प्रश्न उत्तर राहून गेलेला असेल तर मग त्यांना मीना दातेकर बोलवून त्यांना सांगतील की तुम्ही तुमचा प्रश्न विचारा. आणि प्रश्न विचारताना तुम्ही सगळे आत्ता सगळे म्यूट झालेले आहात, तर प्रश्न विचारताना तुम्ही स्वतःला अनम्यूट करा, प्रश्न विचारा आणि प्रश्नाचं उत्तर मिळालं की पुन्हा स्वतःला म्यूट करा, म्हणजे मग गोंधळ होणार नाही. तर आता डॉक्टर वार्देकर, द फोरम इज युअर्स.
So now we are going to talk today. I am again going to speak in Angla भाषेतच बोलतोय, speak in English, and I wanted to continue the same talk, going in little more depth of the main problem which is plaguing us and killing millions of people, and that is the coronary artery disease. 58 million Americans have at least one form of coronary heart disease, and 50% of all cardiac deaths result from coronary heart disease. Canadians are not far behind. 14.8% of those between age 65 to 74 years are reporting having heart disease, and of which is the coronary artery disease is the dominant one. And they also suffer, about 7.1% of people also suffer from the effect of stroke, which is again a part of the arterial disease itself. So that is the reason I decided to go into the depth of coronary artery disease. Once you understand why your coronaries get obstructed, how they get obstructed, what are the elements which are playing part in it, you will have a clear understanding of what is going on. Because normally we hear, he was perfectly fine, he was jogging, and then next day he had a heart attack. How come? He was such a healthy person and he got a heart attack. This is a common occurrence. Once I go over this, you will have a clear-cut understanding of why and how this is happening. Let's not waste any more time and let's dive deep into it. What is coronary artery disease? Coronary artery disease is a disparity between demand and supply. We talked about that in the last talk. Demand is created by when our body does more work. It requires more blood supply, more oxygen, more nutrition, and that is supplied by the heart by increasing either the heart rate or the stroke volume. We talked about all that. And the dominant feature is that the heart rate keeps on increasing and increasing and increasing and keeps up with the supply needed for our body. But when we ask the heart to do more work, it also requires its blood supply. And that blood supply is given to it through the two pipes, coronary arteries, which is one in the front, one in the back, and there are many branches of that. We will not go into the depth of it. So that coronary artery keeps on supplying blood to the heart so that it can keep on increasing its work. How does it increase the supply to the heart? By only one major phenomenon, that is the coronary arteries start getting bigger and bigger and bigger, and they can become 3 to 4 times in their size. So a small pipe has suddenly become this big a pipe, and a lot of blood starts going to the heart, and heart never suffers any lack of blood supply. So that is how the coronaries manage to supply. When there is a disparity produced, when the supply cannot meet the demand of the heart, that's when we start suffering the problem. And that problem is what we are going to study today as a coronary artery disease. So to understand that, this is a normal coronary artery. As you can see, it has got 3 layers. The outer layer is the adventitia, the middle layer is the media, and the inner layer is called as intima, which is lined by a single thin layer of cells, endothelial cells. In this lumen, the blood is flowing. There are white blood cells, and there are red blood cells, and the platelets and whatnot, and the nutritive substances. One of them is LDL particles. So through that blood, all these things are normally flowing through that lumen. One major function of this endothelium is it does not allow any of these substances to go through its wall. So it acts as a barrier. That is the main major function of this endothelium. It forms a barrier. Then nothing percolates and goes through this barrier. Secondly, what it does, it secretes certain substances which does not allow blood to clot on the surface of this inner aspect of this artery. So it keeps everything in a dissolved state so that the blood can flow and you should not have any problems. As you can see here, this is an artery like any other artery. So let us assume that this is a coronary artery, and this artery comes here and it bifurcates into the left and a right branch. Right at the bifurcation, what is happening? The lumen of this artery, which was much bigger here, has become suddenly smaller in this area because there is a bifurcation, and there is also a change in the direction of the blood flow. So suddenly the blood which was flowing in this direction has now started flowing in this direction and this direction, shown by this arrow. That creates, when there is from a bigger artery, the artery has become smaller and there is change in direction, that creates turbulence. And that creates a jet of flow or jet of blood, which is hitting the inner aspect of this bifurcation. So that is the area where most of the arterial disease happens, because at the bifurcation, the blood flow has become faster and the speed has increased, and there is a turbulence of the blood because it has changed direction. And that is what is shown here, that right at the bifurcation, you can see the atheromatous changes or the blockage of the artery initiates or starts. This endothelium, I told you, has normal function is to protect you from getting anything going through it. Once it gets damaged, either because of the jet of blood hitting it on the surface or high blood pressure, if you have not uncontrolled hypertension, this blood pressure is the pressure exerted on these walls of the artery, or toxins like tobacco, or these LDL particle itself, they are toxic to the endothelium, and they produce a damage to the endothelial wall. That is what is being detected. The endothelial wall has become damaged. Once it becomes damaged, the LDL particles become very delighted. They go and they immediately start gathering in the area of this damage. And in this damaged area, the endothelium has lost its protective property, that it was not going to allow anything to get into the wall of the artery. That protective barrier is lost when the endothelium becomes damaged. And all these LDL particles, which they gather here, and they also migrate inside underneath the endothelium, they gather here in the subintimal layer or in the intima itself. As soon as this starts happening, body has always a protective mechanism, always. So what happens? These cells, which we called as monocytes, they're circulating in the blood, suddenly become very active. They immediately want to get rid of this junk. So they immediately come to that area and they start eating up. You can see the Pac-Man-like picture. They start eating up these LDL particles very rapidly, trying to clear this area of any LDL deposit. Second thing which happens, once the LDL gets caught in this area, it gets oxidized. So now you can see, you have heard the use of antioxidants, where it might be working. It will stop the LDL from becoming oxidized. What happens when the LDL becomes oxidized? It becomes chemically active and it starts sending messages to more monocytes to come here. All the monocytes, they come here, and also this LDL migrates through this wall into the subintimal layer. So they enter inside the intima, and this is what is happening. Now, all these Pac-Man-like cells, which were the monocytes, they gobble so much of fat that, see, look here, what they have become. They become fat-laden, and they become big and giant. That's why they are now called as macrophages. And these macrophages are full of this lipid, and that looks like bubbles inside these things. So that's why their name is also changed, and they are called as foam cells. So this is all actively is happening just because you damage your endothelium, either because of the high blood pressure or during bifurcation, you had this jet acting on it, or excessive use of tobacco, and so on and so forth. All that caused endothelial damage, and then this cascade of events started happening. Ultimately, all of these migrates under the endothelium. This endothelium repairs and covers it over, and what you develop is this area which has gone underneath, and that forms what we call as a fatty streak. This all gunk which has entered into the intima now has become chemically active because it has become oxidized. So what it starts doing, it starts attracting more and more monocytes. So monocytes from this blood start coming in, more LDL coming in, more foam cells coming in, and ultimately these gluttony, what is called as gluttony, these phagocytes, they eat so much of fat that they die. Basically, they die of overeating. And once all this thing happens, what it does, this has become a chemically active dump. And this chemically active dump attracts the muscle. You remember the media layer? The muscle cells from media, it attracts them, and they migrate from media into the intima. So now you have got all this collection of this debris, the dead foam cells, the macrophages, the LDL particles, and all this forms this heap, which is not very good. So what does the smooth muscle cell does? the smooth muscle cell starts secreting fibrous tissue and collagen, and it covers that whole area up so that this gunk is not exposed to the flowing blood. So there is a fibrous cap which covers the whole area of gunk, because this whole gunk has got another bad property, that it causes blood to clot. So if the blood will come into contact with this gunk, what it is going to do, the platelets are going to stick to the surface, and there's going to be a clot formation which may produce further blockage. So to protect us, this is a protective mechanism. But in the result, what has happened? Look at this lumen now. This lumen, which was this wide, has now 1/4 of it has been covered up because of formation of this plaque. And all this started with the single thing, which is the endothelial damage. This is how in the cross section the whole plaque looks. Everything inside you see the lymphocytes, the collagen, the lipids, the phagocytes, and everything is covered by this fibrous capsule or fibrous plaque. This is a stable state of affair. Although what has happened, the lumen of the artery has become narrow, isn't it? You see here, this artery, which had a lumen from here to here, now half of it is occupied by this fibrous plaque. So the coronaries have become, the lumen has become only half of what it was to start with. So this is the genesis by which we develop slow and gradual obstruction of the coronary artery. Later on, what will happen, because this thing is now protruding inside the lumen and this has become narrow, there is more force of blood going through here. Because of that, this thing gets eroded. When it becomes eroded, more LDL forms, again a fibrous cap forms, more LDL sticks, more fibrous cap form, and ultimately, slowly over the months and years, you develop gradually progressive blockage of your coronary. That's how your coronary becomes blocked. But besides that, this gunk, I told you, has a property that it causes clotting. So by accident, if there is a breakage in the coverage, what happens? This gunk is exposed now to the blood, and that promotes clotting, and there is suddenly a big clot forms, and that big clot completely obstructs the coronary, producing an acute coronary obstruction. So this is the chronic process of gradual obstruction, and this process produces an immediate, complete obstruction because of this formation of a clot in this area. Now, same thing I have depicted in the longitudinal section for you to understand that first there was deposit of this lipid, and then there was this capsule formation, then this capsule ruptured, and then there was a clot formation, and then clot completely blocked the artery. So this is the progression, how your coronaries become blocked. And this is that phenomenon, the entire process from here to here, and then this rupture of this area sometimes in future, producing this clot formation, producing sudden occlusion of the coronary, producing what we call as an acute heart attack. So we talked about this flow of the coronary. As the coronaries are becoming blocked and blocked and blocked because of that fibrous plaque formation, the blood flow through the coronary, what happens? The coronary, suppose it was of this size, and it starts expanding. It can become 4 times the size of its normal size. So even if it is half blocked, there is still enough blood flowing through. So as you can see, even up to the 75% blockage, the blood flow to the heart does not suffer, because there is so much of potential for the coronary artery to dilate, to become bigger and bigger. But after a certain point, after the coronaries have become more than 70% blocked by this phenomenon, it starts suffering dilatation alone cannot compensate for the obstruction. And then the blood flow to the part which it was supplying starts coming down very rapidly. Now you also see the lower part, the resting. Suppose you are a vegetable person, means vegetable means basically doing very little, going from here to shop and come back and sit and watch TV and do very little activity. During the resting phase, you can have an 85% of occlusion and you will never know that your coronaries are obstructed because the blood flow is enough to maintain you that there is no imbalance between the demand and the supply because you never increase the demand because you were just sitting and vegetating. So that is why people say, oh, he was perfectly fine, he was healthy, nice, everything fine. But by the time the plaque formation, which I showed you, had progressed even up to the 80 to 85% of blockage. And then on one day when he tried to do something, wife said, cut the lawn or clean the snow. And he went and picked up that snow shovel, suddenly increased the demand. That's where the demand and supply calculations went wrong and he started suffering from the problem. So when you develop this gradual slow obstruction, the features which you develop, so what is happening? The coronaries are becoming narrower and narrower and narrow. So during rest, he's feeling fine. But when he tries to do something very actively, when he tries to do something active, like let's give an example that he has got say 15 stairs, which he climbs every day. Suddenly what happens, the artery has started, it has not happened suddenly, but over the period of years, the artery has become narrower and narrower and narrower and narrower. So after walking about 10 steps, he starts feeling a little tightness in his chest. I have described all that thing in my first part, what kind of pain you feel. So he started feeling little tightness in the chest. And he stopped for a while, and the pain gradually disappeared. And then he completed, out of that 15 steps, after 10 steps, he felt that little tightness coming in the chest. He stopped for a minute or so, and the pain disappeared, and he again finished the 5 steps which were remaining. And he keeps on doing this. He knows now that after 10 steps, I get this tightness in the chest. And it is very predictable. Every time when he will walk those 10 steps, he may start feeling little tightness. So by protective mechanism, what he does, he slows down his pace. So instead of he was just running up the stairs. Now he takes his time. And when he takes his time, again, basically you're doing, you're decreasing your demand. So your demand and supply come in the balance and you don't feel anything. So he keeps on doing it. This presentation is called as stable angina. Means you get pain doing a particular activity at a particular level. You go for a walk and there is an uphill. You go half of the uphill, you start getting this tightness of chest. You slow down a little bit, wait for a minute or two, and the pain disappears and you finish the hill. This whole pattern is very repetitive and very predictive, and you can say this is a typical stable angina pattern which happens with the chronic obstruction which I just now demonstrated to you. The second part is the unstable angina. That happens when the occlusion becomes suddenly more marked, either because of formation of a clot in that area. So that produces a sudden blockage, and that makes your angina unstable. When we say unstable, what has happened? Nowadays, when he knew that when he walks 10 steps, he was getting his tightness. Now he starts getting the tightness after 7 steps. Or when he was walking outside, there was a hill coming. He was going half of the hill first without any problem. But now 1/4 of the hill, he starts having tightness. So the nature of his pain has changed. It has started coming earlier and earlier. So if there is a change in the nature of your pain, that is the less and less activity is starting to bring on this tightness, you can say your angina has become unstable and you should act on it. Second thing which tells you that it has become unstable if the frequency increases. Initially you had this chest pain maybe once every month. Now you started noticing that every 2 weeks there's a time when you feel this tightness coming. So the frequency has increased. Or once it comes, it used to last a minute or two, but now it is lasting 3, 4, 5, 6 minutes. So the duration has increased. So frequency has increased, duration has increased, the distance which you traveled, which produced pain. If any of these changes, it means your angina has become unstable. And that is the point where you should not ignore it. There's something acute is happening there. And that's why you should seek medical attention. All this I described to you to give you a warning how your nature of pain will change, which will alert you to seek medical attention and not to ignore that. If you have got a stable angina pattern and it is going on, probably it is not that risky because it has a stable pattern. The demand supply, you know exactly when the demand is going to exceed the supply. But unstable condition, things are changing. So you have to be very alert. If you develop a complete sudden blockage, what is going to happen? The supply of that muscle, heart muscle, is completely cut off. When it is completely cut off, that muscle basically dies. And when it dies, in medical terminology, we call it as myocardial infarction or a heart attack. So that is the difference between angina and a heart attack. When the arterial supply is completely cut off and then part of the heart muscle dies, then that is called as a heart attack or myocardial infarction. And that happens with this sudden obstruction, not with this chronic progressive obstruction. That produces angina, first stable, then unstable. Once this become unstable, it means it may be progressing to this place. So be attentive, seek medical attention if you notice something like that. The third thing which the coronary obstruction can produce, if a certain part of the heart is not getting enough blood supply, that muscle function starts gradually getting lesser and lesser. And that presents itself what we call as a heart failure. We talked about all these things in the past, how this is happening now. As the blood supply started getting lesser and lesser, your heart muscle was not provided the nutrition it required. Its function became less and less. Its contraction becomes more feeble, and you develop features of heart failure. Same lack of blood supply, if it affects your electrical system of the heart, then you start developing problem with heart rate changes. Either the heart will suddenly slow down too much, or it will suddenly become very, very fast, which we call as ventricular tachycardia or ventricular fibrillation, or you start developing extra heartbeats, skipped beats, jalamantar. So all these things start happening just because the blood supply to that particular area is being affected. If it's of a catastrophic nature and it shuts off your electrical system, it can produce sudden death. So the man was perfectly fine, and suddenly the electrical system got shot because there was a clot completely blocking that coronary artery, which I have shown you, can produce a sudden death. Now, why this happens? Why exercise brings these problems, and how we can exploit it to our advantage? What happens? Okay, let us see that there are these two coronaries. One is going into the front, one is going in the back. And this coronary artery is diseased. The front one is diseased. Now what starts happening? You start exercising. When you start exercising, your body needs more blood, so your heart has to pump more. And this heart itself needs its more blood supply. Now, when it needs its more blood supply, this coronary is blocked or partially blocked. It cannot increase the blood supply to this area of the heart. what starts happening? This heart starts complaining, I'm not getting my blood supply, I'm not getting my blood supply. And to correct the problem, body has all these reparative mechanisms. To correct this problem, this heart muscle starts secreting certain very active substances which cause dilatation of the coronary arteries. So basically, there is a built-in protective mechanism. When this part of the heart muscle, this area, was not getting enough blood supply, it will cause to liberate certain dilating substances which will cause coronary vasodilatation. Now, this artery is already blocked because of that big plaque which I showed you there. So that plaque does not allow this artery to dilate. But what has stopped this artery from dilating? Nothing, because this artery is completely normal. So when you exercise, this muscle is not getting enough blood supply. That causes release of this dilating substances, which not only act on this artery, but acts on this artery and causes this artery to become bigger. So what happens? Now the blood is coming and it finds there is a resistance in this area because of the blockage. But this area is wide open because this has become even bigger. So all the blood is diverted from here to this area. So basically, by doing exercise, you are basically diverting the blood from the sick area, from the area which was already not getting the blood supply, to healthier area. So basically, this artery, your normal artery, is stealing the blood from your abnormal artery. So that is why when you start working or you start making your heart do the work, heart starts working, lack of blood supply gets exaggerated, vasodilators are secreted, the normal coronaries get dilated, the abnormal coronaries don't get dilated, and the blood is diverted, and you start getting more production of pain. This property we exploit in our testing. How do we diagnose that you have coronary artery disease? The one is the investigation for effects of obstruction. So what happens when that part of that heart muscle is not getting enough blood supply? It produces certain changes in the electrocardiogram. And the first test which normally any doctor orders on you is an ECG. So the ECG, but the sensitivity and specificity of ECG is very low. You know why? Because when they are doing the ECG, are you dancing? No, you are lying quiet, peacefully on a bed, and the technician does your ECG. So when she does the ECG, when you are completely perfectly lying in the bed, your demand and supply has become again normal. So many times the ECG misses out to make a diagnosis of coronary artery disease. And it has got an ability of about 50% to detect presence of or absence of coronary artery disease. Compared to that, when you are going to exercise, when you make the patient walk, after that you do ECG while he's exercising, now what you have done, you have produced that imbalance which he was noticing when he was climbing those steps. So that imbalance is brought on there, and because that imbalance is brought on, and that imbalance is even exaggerated by the mechanism I told you because of the vasodilatation of the normal coronaries. So it starts producing typical changes in the electrocardiogram. I'm going to go in a second to give you the data about these things. Same time, the second test which we can do is we can take a picture of the heart by injecting a radioactive isotope, either cis-TeMe or thallium. And if the blood is flowing to that area, that area will light up. So we have gamma cameras and we take pictures of that lighted up of the heart. So if the blood is flowing to all the areas, all the heart will light up uniformly. But if one side of the heart is not lighting up, then that means that coronary artery is blocked. That's why all that the radioactive material which I gave you, IV, did not reach that part of the heart. And that is exaggerated by exercise. So that is the thing which we test by doing nuclear imaging by thallium
You must have heard of this test, thallium stress test. So that is what that thallium stress test is. Thirdly, when I told you that when the heart muscle does not get enough blood supply and you have produced this disparity by exercising it, what starts happening? The heart muscle starts beating less forcefully. So typically what we will see when we exercise the person, instead of beating more forcefully, now you have exaggerated the disparity. That is what I showed you in the beginning. And you start getting less motion of the ball. That is detected by exercising followed by an echocardiogram. So these are the three tests which we do to find out the effects of obstruction and at what level of exercise these changes are being produced. To see direct how much the coronary is obstructed, there are two tests. One is a non-invasive test, which is called as Coronary Ct Scan. And second is the invasive, in which you have coronary angiogram, that they pass a catheter and they inject certain dye and they look at your artery. Now, just to show you the accuracy of the CT scan, coronary CT scan, is pretty decent compared to angiography, 71%, 69%, which is pretty decent. So even with a totally non-invasive test, you can get a very good idea about whether your coronaries are significantly blocked or not. I particularly entered all these things because Sri Murugan had pointed out to me he wanted to know about tests. And so this is the reason I included this part into today's talk. But I wanted you to understand the rationale behind all these talks. Okay. Now, if you do exercise and just ECG, the sensitivity and specificity is 68% and 77%. If you do with nuclear imaging, that is with thallium or with stress echo, the accuracy is close to 90%. So it's a much better if you are suspecting somebody, and there is a Sriram will be knowing that much better than me, that if there is a pre-test probability is high of suspecting that this man has coronary artery disease, the stress exercise ECG is good enough. But if the pre-exercise probability is low, then you should go for a more sensitive test. So that is, but this is not a decision you take, this is the decision your doctor takes, but you should be aware of these tests. And I wanted to specifically spend a minute of time here. The reason I wanted to spend a minute of time here was, this is the standard stress test which we ask you to do. Normally starting point, that is called a stage 1. We start at a 1.7 mile speed and you are walking on an incline of 10%. That raises the heart demand 4 and 4.5 times the baseline. So if you are doing nothing, if your heart demand is of 1 MET level, but at stage 1 of Bruce, that is walking at 1.7 miles at 10% incline, your body requires 4.5 times the amount of blood that compared to when you were at rest. We keep this stage for 3 minutes, and if there is no abnormality noticed, we take you to the stage 2 and we make you walk at 2.5 miles per hour. And we increase the incline by only 2%, so 10% to 12%. This increases the demand of the heart by 7 to 7 METs. And third stage is 3.4 miles, 14% incline, and that increases the demand to 10 times. Many times you come and you give me a call, Doc, I had a stress test and everything was normal. I was told everything was normal. And I usually ask you, how many minutes did you walk? Now you understand why I asked you that question. If you walked for 9 minutes, see 9 minutes. If you walk for 9 minutes, it means you raised your requirement 10 times the baseline. And still your ECG did not change, your thallium image did not change, your echocardiogram did not change. That is a wonderful news. It means even when the heart requirement was raised by 10 times the baseline, no changes occurred. It means the coronary arteries are dilating very well and coping up with the demand. So please pay an attention, or after you get a stress test done, please ask how many minutes I walked and what stage I reached. That one information tells me a lot about how well you did. And it will tell you also that, okay, I raised my heart demand to 10 times and nothing wrong was found. It means my coronaries are in good shape. So that is the reason I wanted to spend this time a little bit more at this level. Okay. For acute heart attack, there are two tests which they do. One is the ECG, which has got and second is the blood test, troponins level. Why I'm telling you this? Just for one question. Many times you go with a chest pain, go to the hospital, they do an ECG. The ECG in the first hour may not change at all. Similarly, the troponin levels may not change at all. But it may take 3 or 4 hours or for the troponin level to gradually rise. The troponin level only rises if you have suffered a damage to your heart muscle, and damage to the heart muscle is myocardial infarction. So it is a very sensitive test and tells you, has got a sensitivity of 85% and specificity of 91%. If troponin levels are normal, your doctor said, hey, forget it, go home, you are fine. So sometimes they ask you to wait for 6, 7 hours, 8 hours, because they are doing the first test, and then after a few hours, they repeat the test to see if the levels are rising. So don't be surprised. मला इतका वेळ लावला त्या लोकांनी ते थांबायला सांगितलं for the blood test. The reason is they're checking is there is a leak because of the damage to the heart muscle, and is the troponin levels are coming up or not. The test for heart function, as you can see in this picture, I can see the heart muscle, I can see the valves, I can see the blood flowing. This is an echocardiogram. So once, if you want to see any abnormality of heart structure and heart function, the test which we do is echocardiogram. So when somebody is ordering an echocardiogram you, it means what he is worried about? He is worried about the structure and function of your heart. So if you are complaining shortness of breath, it means what? It means whether he wants to know whether it is coming from lung or heart. And echocardiogram will tell them that if the heart function is normal, the heart is not the culprit, because the heart systolic function is normal, which is shown by the contraction and relaxation of the heart muscle. The Halter test is ordered when you complain of palpitation or skipped beats or jumping or skipping, something like that. So electrical abnormality of the heart is determined by Halter. Functional abnormality of the heart is determined by echocardiogram. Coronary abnormality of the heart is determined by the ECG and the stress testing. So that is, I'm not going to spend even half a minute on the treatment because that is not your domain. You're not going to treat yourself. But first, reduce as many risk factors as you can. If your blood pressure is out of control, bring it under control. Obesity, control. Smoking, stop. Cholesterol levels, bring it down to the normal level. Lifestyle modification, add exercise and stress reduction. Rest of it is meant for the doctors. So I'm not going to spend at all any time. I don't want you to become doctors or argue with the doctors. Okay, now this part is finished. There are many questions which are constantly hounding you, and media constantly keeps on harping, or you read somewhere, or you read an article. Stress and heart disease. Someone asked me this question, I think Mrs. Paranspe asked this question about transcendental meditation and stress, whether stress has got any effect on the heart. Yes, so I'm going to deal with these questions. Role of stress, role of transcendental meditation, use of garlic, whether I should eat garlic or not, use of antioxidant, खूप ऐकलंय antioxidants, should I take it or not? Fish oil, everyone talks about, should I take fish oil? Should I not take fish oil? How much should I take? Is coconut oil good for me? Is coconut oil bad for me? And a word about your lipids and triglycerides, role of diet in prevention of coronary artery disease, prophylactic aspirin use. Should I take aspirin? Should I not take aspirin? My doctor told me to take aspirin. Should I be taking it or not? So all these different questions I have tried to answer one by one. Let us talk about acute stress. Does stress affect your heart? There's ample data there to show that yes, during earthquake, there was an increased incidence of myocardial infarctions and coronary deaths significantly, and this was documented in this 1994. There was a sharp rise in the death due to arteriosclerotic cardiovascular disease during this time, and this increase lasted for almost 6 days after the episode. So there's no question that during the acute stress, it does affect your heart. So there's enough data so that stress does affect your heart. Not only that, 67% of coronary artery disease patients, they developed abnormality in the motion of the ventricular wall when they were given a mental arithmetic problem. I think I will have more problem because my mathematics is very weak. So if probably my abnormality will be much higher when I'm given a mathematical problem. But it has been documented by showing on in a picture that there is a decreased blood supply which happens when they were stressed by giving a mathematical stress. Those people who developed these abnormalities on mathematical stress had a 2.4 times more episode of heart attack during the follow-up period. So what I'm trying to just show you that stress does affect your heart. This is the picture. You see this picture? This is how that SESTMB or thallium scan. See, when it is going and it lights up the whole system, he was given a mathematical problem. Look at what happened here. The blood disappeared from that area. So you can see that it is not imaginary. It can affect, it has been documented, so stress does play a role. Somebody asked me this question, so I'm elaborating on that question. This is a particular disease which has been recently documented, which is called as broken heart syndrome. This is a true broken heart syndrome. Somebody had a bereavement, suddenly life partner lost, or a major catastrophe, financial catastrophe, loss of a house, some major loss. In these people, they suddenly come to the emergency room with chest pain, shortness of breath. And when you normally do an angiogram, during systole, the heart should empty, isn't it? Just like that. But in these people, the heart does not empty. This is a picture of a systole. In the systole, heart should have looked like here. But instead of that, heart looks like it has become bigger. It has become dilated. Only the neck area is contracting and the rest of the heart has become swollen or not contracting. This disease is called as a broken heart syndrome. Fortunately, it is a self-recovering disease. Most of the patients recover after a few weeks, and it does not leave them with a significant damage. But it is a well-known disease, and the picture of the heart resembles a Japanese lobster trap, Takotsubo. So that's why it is also called as the Takotsubo disease. If somebody just mentions it, this is so stress. All I'm trying to show you, stress affects your heart. That was the acute stress. What about the chronic stress? Yes, the chronic stress also affects your heart. I'm not going to go over the data. One thing important, whether it is the stress at the work or whether it is the marital stress. Marital stress is associated with 2.9-fold increase in the risk of recurrent event. So we are not very safe, are we? So having a happy married life is fantastic for your heart health. No question about it, because this is the data about the chronic stress. Similarly, in a 4-year period, caregivers who had a lot of more stress had a 63% higher mortality than the non-caregivers. So basically, whether it is an acute stress or chronic stress, it affects your heart. And does transcendental meditation help? This is the data of the transcendental meditation, a study done on 201 Black men and women. And as you can see, there was a 48% reduction in primary endpoint in the people who participated in TM. Also, there is a reduction of the blood pressure and the pulse rate with transcendental meditation. So if you have stress, all those blood pressure factors which I told you, all that jet effect which I told you, you can reduce all that by reducing your stress level by doing transcendental meditation. So this is another study which was performed. A person was given isoproterenol, which increases your heart rate. And the patient started meditation here. And you can see the heart rate dramatically dropped, completely dropped. So what I'm trying to show you, म्हणजे lot of people say, they yogi लोक असतात ते काय काय बोलत असतात. So there is a truth behind it. It has been now documented by scientific data that yes, it happens. So there is no harm in doing it. It's not going to hurt you, for sure. And if at all, it may help you. Okay. Garlic. Should I eat garlic or should I not eat garlic? Garlic has an ingredient which is called as allicin, which is when we crush garlic or cut garlic, there's an enzyme which is called as allinase, which becomes active and which converts alanine to allicin, which is the active gradient of the garlic. Garlic has got so many potentials. It reduces blood pressure, systolic by 20 to 30 millimeters, diastolic by 10 to 20 millimeters. It reduces platelet aggregation. I showed you that picture. Now you understand why I showed you how it is happening and what you are doing to reduce your chances of developing that obstruction. So it reduces platelet aggregation. It breaks up the clot. It causes fibrinolysis. So even if there is a clot formation, garlic can break up, active substance of garlic can break up that clot. It reduces the pulmonary pressure. It reduces the stiffening of the aorta. It reduces the LDL triglyceride. It has an antioxidant effect. So now you can understand why garlic will help, because I have shown you how your coronaries get occluded. There is the effect of the blood pressure. There is the effect of oxidation of LDL. All these factors, there is a clotting mechanism. All these factors are reduced by garlic. How much garlic? And another important thing, the CAC score. We talked about CAC score in the previous lecture. The CAC score progression, that is the calcium deposit which is happening, which is deposited by the smooth muscle cell, which has migrated into the intima. That CAC score progression is reduced if you take garlic on a chronic basis. Side effect, yes, it will give you a bad breath. Of course, garlic is smelly. Whether it is a bad breath or good breath, it's difficult to say, but it has a garlicky smell. Even your sweat can smell garlicky. Some people can have allergy to garlic and can cause skin rash or eye irritation or asthmatics, bronchospasm. Can have nausea, bloating sensation. And the dose of garlic is about 600 to 900 milligram powdered garlic. That is what is the recommended dose. And it has got all these beneficial effects. So the simple answer to the question of garlic, is it helpful? Yes, it is helpful. Is it helpful to reduce stress? Yes, it is helpful. Is TM helps? Yes, it helps. Okay. Coenzyme. A lot of people talk about coenzyme. Does it help? Well, if you believe that oxidation of LDL makes it chemically active and starts attracting more monocytes and more all those chemical reaction happening. One of the studies which was done, the incidence of coronary artery disease is higher in Indians, and our CoQ levels are low. So there is a indirect evidence that when in a society where the CoQ levels were low, there is increased incidence of coronary artery disease. Similarly, an incidence was noticed between Greenland people and Danish people. The low incidence of coronary artery in Greenland people compared to Danish people, as Greenland people have a higher CoQ level. So basically, it seems that when Indians had low CoQ level, we get more heart attack. When Greenland people had high CoQ level, they are protected. So it seems, and we have also seen the mechanism, how it works on the oxidation of LDL. It will prevent its oxidation. So all that future further reaction. It has got anti-inflammatory property, antioxidant property, antithrombotic property, and antihypertensive property. So there's not a bad idea to even take a CoQ. And the dose of CoQ is 100 to 300 milligram. Okay. Now, yache dose mi ka tumhara sangto hai? Because these are usually you are taking it over the counter. Because usually, and that is the reason I am telling you how much to take. If you decide to take, how much you should take. That is the reason I'm giving you. I'm not giving you the doses of what your doctor prescribes. Fish oil is a very, very common question. Everyone is talking about fish oil. Taking fish oil does this, taking fish oil does that. Does it actually work? American Heart Association scientific statement says that yes, if you take EPA and DHA, which are the two ingredient of the fish oil, it reduces the triglyceride by 30%. And unfortunately, it reduces the triglyceride, but increases your LDL level, which is not very good, isn't it? But if you take fish oil, which only has EPA, that does not raise LDL. So if you want to take a fish oil, which fish oil you should take? Not the one with the EPA and DHA, but you should take one with the EPA alone. Got it? Okay. Now, another question is whether I should just order it from Amazon, which is basically a supplement. It comes under the label of supplement. When you have a supplement, they are not controlled. They are not controlled at all. So that is the reason I always suggest that if you want to take fish oil, take prescription fish oil. And these are the names of the prescription fish oil, of which Vasepa fish oil only has EPA, so it will not raise your LDL level. So if you are going to ask for a fish oil from your family physician, ask for Vasepa. Okay? Coconut oil. One serving of coconut oil, a lot of talk is going on coconut oil. So one serving of coconut oil has got 12 grams of saturated fat in it. And the coconut oil raises your LDL by 10.47, but it also raises your HDL by 4 milligram. Overall, American Heart Association recommends no more than 13 grams of saturated fat per day in your diet. If you are taking coconut oil, it is going to give you 1 tablespoon of coconut oil is going to give you 12 grams of saturated fat. So your entire requirement of saturated fat is over by coconut oil. So everything I was endorsing, I'm not endorsing that much use of coconut oil. Doesn't seem to be having that much of benefit. It raises your LDL level and it loads your LDL. This was the normal levels, which I'm not going to go over it. These are the normal levels of there are many types of cholesterol: total cholesterol, HDL cholesterol, LDL cholesterol, triglyceride, and non-HDL cholesterol. So there's always a confusion about it, non-HDL cholesterol. So all these cholesterols we know, and Shri Murugan pointed out to me, why are you telling this in milligram? So I have given you it in mmol because we are more used to mmol. So these are the normal levels, and you should be aware of it because you always get your blood test. So you should be aware, and these slides are going to be provided to you in the PDF format. So you have the reference with you. So I'm not going to spend time on this. We talked about Birmingham study. And in Framingham study, if you're in a high risk area, you should try to bring your LDL below 2. That is what is recommended. So 3.5 is not good, 3 is not good. It should be below 2. If you're Framingham, and I have I have explained Framingham study in the past lecture, so I'm not going to go over it. Similarly, if you have got one additional risk factor, you should also target to reduce your LDL level. This I have shown the number of people treated who benefit. So if you treat 35 people with the high risk, by lowering their LDL, one will benefit. If you treat 40 in the intermediate risk, one will benefit. And if you have got clinical coronary artery disease established or you are diabetic, even treating 20 will produce the beneficial effect. So these are some conversion tables, which are going to be provided. So I'm not going to spend time there. A word about triglyceride, because Indians have got high triglyceride levels. Most of us have got high triglyceride levels. And these are the normal levels. These are the conditions which raise your triglyceride. If you're obese, your triglyceride level will go up. If you have metabolic syndrome, your triglyceride level will up. म्हणजे तुमचा वेस्ट गर्थ जर जास्त असेल तर ट्रायग्लिसाइड तुमचं जास्त असतं. Diabetes, if you have diabetes, triglyceride is up. If you drink alcohol on a regular basis, your triglyceride will go up. And there are many other conditions. The list is given to you. You can go over it. Treatment, if your triglyceride is up, we want to reduce it. Simple measures: weight reduction, carbohydrate reduction, not fat reduction, carbohydrate reduction, alcohol reduction, removal of the offending drug, treating the underlying cause, and certain medications, which is again not your domain. If required, your doctor will prescribe, but you should be aware if you're taking any one of these drugs, it is probably given for reducing your triglyceride level. So if somebody is giving you a fibrate to take, that means your triglyceride is also up and he's trying to bring it down. I'm not going to go over this. Okay. Food and cholesterol. I wanted to go over this just briefly. If you eat less cholesterol, your liver makes more of it. And if you eat more cholesterol, your liver makes less of it. So diet has got a very little impact on your total LDL cholesterol level. No more than 10%. So if suppose your LDL cholesterol level is 5 and your target level is 2, which I showed you in the Framingham, if it is going to come down by 10% by you eliminating the fat completely, म्हणजे तुम्ही खाणंच बंद केलं तेल आणि तूप, your cholesterol is going to drop by only 0.5. Is it going to bring it to 2? No, never. So diet, so don't kill yourself going over the diet to try to control your LDL cholesterol. That is at least I'm giving you one good news. रोज भाजी खाऊ नका, पण मध्ये मध्ये खाल्लं तर don't stress over it, because the impact of diet on your LDL cholesterol is comparatively very less. There are 40% of people where the cholesterol level, LDL cholesterol, does go high, and these people, it is genetically predisposed. But when their LDL rises, their HDL also rises. So basically, their incidence of coronary artery does not increase. So basically, by eating fat, you are not going to make your chances of getting coronary artery more than usual. And this is the explanation for it. 2 grams of cholesterol is secreted by the liver into the intestine. And food has around 400 milligrams of cholesterol in a normal American diet. 1.2 gram of this, the 2.42 grams, so total 2,400 milligrams is in the gut every day, of which 1.2 gram is lost in the stool. That lost portion is only made up by liver. So if you start reducing the cholesterol, that is this 400 milligram, your liver starts making more and more. So that is why by dieting alone, you cannot cut down. It has got other benefits. It has got benefit of reducing your weight. But if you want to reduce your LDL, की आजपासून मी फॅट खाणं बंद केलं, त्यांनी तुमचं LDL कमी होणार नाहीये. So basically, the moral of the story is you are going to require something else to reduce your cholesterol level. This is a general idea about fat, how much saturated fat you should take, and how much fiber is an antidote for your fat intake and your carbohydrate intake. So if you take fiber along with your diet, it reduces the absorption of fat. It also reduces the absorption of your sugar. Aspirin, basically, I have to say only two things about aspirin. If you have got a high risk on Framingham scale, you should be on aspirin if you do not have high risk of bleeding, GI bleeding. If you are above age 70, routine use of aspirin, it used to be done. Now it is not suggested. So if you are over 70, you are in the intermediate risk group, unless there is one or two more risk factors present, and unless I know that you have got a low bleeding risk, I will not like to prescribe you aspirin. It has been found very useful in people with between 40 to 70 years of age to take aspirin to prevent coronary artery disease if they have got low bleeding risk. This table basically tells you how to calculate your bleeding risk. I'm not going to go over that. So, okay. Daily, in 2 more minutes, I will stop. Calorie you burn, 80% of the calories, 60 to 80% of calories you burn doing nothing, sitting quietly, breathing. That is called as basal metabolic rate. 10% of your calories you burn by your food intake, calorie burn by food. 15 to 30% of the calorie is given to the activity, of which exercise, how much can you exercise? 30 minutes, 45 minutes, 1 hour. So you can only burn about 5% to 10% max of your calories by doing exercise. So exercise is not the solution for burning calories. What burns your calories is NEAT activity. I'm giving you this example. This is a 45-year-old female. What she was doing, her BMI was 132, her weight was 180, and she was doing 8 hours of sitting work, and ghari un basun, she used to just watch TV or do something else. But basically, not much of an activity. And this was her situation. All she did was, instead that work, when she was doing the work, she added 15 minutes of standing every hour, not throughout the hour. So out of the 8 hours of work, 15 minutes she was spending doing the work, same work which she was doing, but in a standing position. That dropped her weight to 172. When she added the same 15 minutes of activity during leisure time, after coming home, 15 minutes per hour, she just went and walked around or started doing something, some other chore like folding clothes or something, some other activity. That dropped her BMI from 32 to 27 and weight dropped to 156. So what I'm trying to emphasize, NEAT is the one which is the non-exercise activity induced thermogenesis. The big name for NEAT is basically you're burning calories while you are not physically doing exercise, but at home doing puttering around. You will burn much more calories doing that, and that I should stop at this point. And this slide basically shows diet and exercise are not 50-50 partners. Diet role is 95%, exercise role is 5%. If total calorie required is 2,500, a 45 minutes walk at 2 miles per hour burns only 105 calories, not even 5%. One slice of bread nearly wipes it off. So pay attention to NEAT activity, not the exercise. Exercise kara, it has got other benefits, cardiac benefits and many other benefits. But if you are doing it for weight loss, nusta exercise nahi tumsa weight loss hot nahi. And I will stop here. There are many additional slides which the PDF will be provided to you. Thank you very much. thank you for giving me an opportunity to give this talk, and I hope I have tried to make things clear.
Okay.
Thank you so much. It was a
Yeah,
very
that
good
was very
presentation.
nice.
Wonderful.
Excellent.
आता आपण असं करूया की लोकांना प्रश्न नक्कीच असतील तर ते प्रश्न विचारण्याकरता मग तुम्ही तुमचा हात वर करून ठेवा, म्हणजे मीना जातेवाडकरांना कळेल कुणाला प्रश्न विचारायचे आहेत. आणि तुम्ही स्वतःला अनम्यूट करा, प्रश्न विचारा आणि उत्तर मिळालं की स्वतःला म्यूट करून टाका. मनोहराने हात वरती केला होता. मनोहर,
Doctor,
yeah.
can you hear me? Yeah.
Yes, I can hear you.
Well, recently my stress test वगैरे घेण्यात आली, ECG and stress test. The stress test मध्ये there were two types of stress tests. You can do either एक on the treadmill and the other one with the injection. So my doctor said, like, you take with the injection. So instead of going on a treadmill, I got an injection. They gave me injection and got the stress test. Is there any difference or?
What basically they are doing when we find that somebody is not able to exercise, I always prefer exercise testing more. If somebody is unable to exercise, or we feel that he is not going to complete the 10 minutes which we wanted you to complete, in that case, we give a medication to speed up your heart. So basically, when we are exercising, what we are doing, we are trying to raise your heart rate and raise your blood pressure. Instead of raising it by exercise, we give you medication to raise the blood pressure, to raise the pulse rate, so increasing the demand and producing that disparity, which will produce the abnormality in if there is anything abnormal. So basically, it does the same thing. The only thing, we use it only in cases where we feel that the patient is either wobbly or unsteady, or he is not going to complete because he has got a knee replacement or something like that, that he is not able to, he will not be able to complete that walking on that, which is going at a pretty good clip, 1.7 miles, then 2 points, I showed you 2.4 miles, and then 3.2 miles, and then 4 miles, and at an inclination. Then we do take care of by giving the medication, and it has got the same, the results are the same.
Because he did not give me any option whether you want this or that. He said,
That is
"No, you take
folly.
this
He should have given you the option.
Yeah.
But in his assessment, probably he felt that you were not going to be able to do the exercise.
Right, probably. Yeah.
That's what his assessment was. And I can't question because I have not examined you.
जोगळेकर, तुमचा हात वरती दिसला होता एकदा, क्वेश्चन आहे का? नाही.
I think I went into too much.
Gulab's hand is there.
मला विचारायचंय गार्लिक बद्दल. तुम्ही जे माहिती दाखवली होती त्याप्रमाणे आपण जे जेवणात खातो त्याने काही फायदा होत नाही, कारण ती फोडणीमध्ये घातलेली असते.
After heating to 60 degrees Celsius, the active ingredient is destroyed.
म्हणजे
so usually they say either eat garlic pearls or cloves, which is very difficult to eat. Don't cloves will be having the same amount which I suggested. So either two cloves or in a pearl form, म्हणजे capsule असतो, so that will not give you a bad taste, or it will not give you, and they are available everywhere.
अच्छा, गार्लिकचं लोणचं असतं ते पण तसंच ना? It is probably marinated.
It's marinated, but it's not heated. The heating destroys it.
Okay.
So it is the heat, 60 degrees Celsius, it destroys it.
So if you crush it and then swallow it, it will be okay.
Should be fine. That activates that allinase. Either crushing or cutting, even cutting.
ओके. आणि तुम्ही तुपाबद्दल तूप लिहिलं होतं तिथे, त्याचं सांगितलं नाही. इज इट द सेम लाईक कोकोनट ऑइल?
I did not go there. Basically, there's between tube and butter, there's no problem in taking tube. They are almost equivalent. They have got almost equivalent properties. The only difference is in tube you eliminate lot of those who are lactose deficient. Those people tolerate tube better than butter, because butter has got all those lactose त्याच्यात असतं. When you convert it into tube, when you evaporate everything, you have taken care of the lactate part of it. So that's why most of the people who are lactose intolerant, they may tolerate tube better than butter. Otherwise, there's no difference between tube and the butter. So be happy with whatever you like.
ओके. थँक यू.
मिस्टर ढोले, तुम्हाला विचारायचे, अनम्यूट करा तुम्ही.
म्यूट कर.
Hear you.
Yeah, I'm being a heart patient for last 10 years, and I do a lot of exercise of biking.
Yes.
And I do a biking about around this summer. I did about 3,000 kilometer outdoor biking. Is it too much for me to do that much bike, or is it okay?
No. How was your performance on the stress test? You must have had a stress test recently in the past.
Stress test was, I can't remember at this point, but I think it was okay.
Yeah.
My
So
cardiologist
if you have, like I also do a lot of exercise, and
Right.
I was known to have coronary artery disease in the past, and that disappeared with exercise, LDL reduction, control of blood pressure. Means my stress test was positive, and it remained positive for 4 years, and then it became negative. So basically, if you are not having any symptoms, you can exercise. I usually say that to determine how much can you exercise, it is always better, not the test which Mr. Manohar had, but to get a stress test, recent stress test. And if you are performing more, like you are reaching stage 3 of the bruise or stage 4 of the bruise, that's what I was reaching, stage 3 to stage 4 of the bruise. It means when my heart requirement was raised to 12 times to 13 times the baseline, my coronaries were able to supply it. So if your stress test levels, if I want to really go into good exercise program like what you are doing, the bicycling, and you are not having any symptoms, one safety measure which you can have is get a stress test done. That will tell you ki kiti वाढवल्यावर तुम्हाला त्रास होत नाही, म्हणजे I am not seeing any changes in your cardiogram. And if on that thing it is raised to that level where you became little tired and little short of breath during bicycling, if you are not reaching that level, you should be perfectly safe.
Okay, the last question is this. Are you available for consulting?
Unfortunately not, but you can give me a call anytime.
Okay, and how do I get your number, sir?
I will send me an email, awardekar@gmail.com.
awardekar@gmail.com?
Yeah, Wardekar, Wardekar.
Okay.
@gmail.com.
And thank you. And I enjoyed your talk so much, and I learned so much, even though I know a lot about the heart, being a heart patient for since 2010. And thank you very much.
You're welcome. It was a little too technical, but I thought that the process involved gives you a better idea of what is going on.
Thank you again.
म्हणजे डॉक्टर वार्डेकर, इफ आय अंडरस्टँड यू करेक्टली, तुमचं म्हणणं असं आहे की इट इज नॉट द अमाउंट ऑफ टाइम विच यू स्पेंड फॉर एक्सरसाइजिंग, but the intensity of the exercise is important.
Yes.
Is that correct?
Exactly.
Okay.
And so if you have gone up to a level of 10 mets in your bicycling, if you are not reaching, and I have also in the past, I had described you what is the allowed heart rate to you. So when he is bicycling or you're doing an exercise, you should not raise your heart rate beyond 75 to 80% of your maximum allowed. And I had given you the formula that 220 minus age is your maximum allowed heart rate. And you should achieve only about 75% or 8 to 80% of your maximum heart rate to achieve the cardiac fitness which he is trying to achieve. त्याच्या पलीकडे you are pushing your luck. म्हणजे तुम्हाला त्याच्यानी जास्त त्रास होण्याचे चान्सेस आहेत, रिस्क होण्याचे चान्सेस आहेत. So I usually tell them, take your pulse before, take your pulse after finishing your exercise. And if you are within that limit of less than 80% of your target heart rate, you are fine. You should be all right because you are not exceeding the limits.
One question. Bisoprolol, if I'm taking a bisoprolol, my heart rate never goes up.
Yeah, I know it is a beta blocker. So that is why that has been given to prevent you from getting second coronary or a coronary attack, and also reduce your demand. And basically what happens, your demand goes down. So if you are, it means your demand is going down whenever you're bicycling. At the end of the bicycle, if your heart rate has not gone up, see, for your age, I'm not asking your age, but whatever your age is, 220 minus your age, that is your maximum allowed heart rate. Try to achieve, not exceed more than 75% of that target heart rate. And you will be safe.
I'm happy to share my age with everyone. I have no problem. I'm 78 years old.
Okay, so 220 minus 78 is your maximum allowed heart rate. That is your, so 220 minus 8 is about 140, give and take 1 or 2, and 140. So your heart rate, if you raise 80% of that, if you exercise, that your heart rate reaches 80% of 140, that is the you should remain in your safe limits.
Thank you.
मला एक छोटा प्रश्न आहे.
Yeah, go ahead.
तुम्ही ते मेडिटेशनचं सांगितलं, ते नेहमी मेडिटेशन आपण जे करतो ते आणि ट्रान्सेंडेंटल मेडिटेशन काही फरक आहे का?
मला सांगता नाही येणार, मी त्याचा अजिबात ज्ञानी नाहीये. म्हणजे ट्रान्सडेंटल मेडिटेशन आणि मेडिटेशन याच्यामध्ये काय फरक आहे हे कोणीतरी आपल्या ऑडियन्स मध्ये कोणी आहे का ज्ञानी? मला फक्त डेटा माहिती आहे की मेडिटेशन केल्याने ब्लड प्रेशर कमी होतं, हार्ट रेट कमी होतं, हार्ट अटॅक्सचे इन्सिडेन्सेस कमी होतात. आता ते
अनुराधा वकील यांचं उत्तर देऊ शकतील. अनु मालू
श्री वकील
मालू, can you answer the question?
Can you shed light on transcendental versus meditation?
Unmute yourself.
Oh, unmute. Okay.
Okay. Yeah.
So the question is directed to you about the difference between transcendental meditation and regular meditation. I am totally ignorant about it.
Well, actually, meditation is same. Okay. म्हणजे it is only the traditions are different. Upon the Indian way we do the meditation, that is we more concentrate on mind किंवा आपल्याकडे जप वगैरे करतात, वेगवेगळ्या पद्धतीने आपण मेडिटेशन करतो. ट्रान्सिडेंटल मेडिटेशन मध्ये सुद्धा तोच फॅक्टर आहे, फक्त तुम्हाला म्हणजे तुमचं हार्ट रेट कसं कमी होतं, तुमचा रेस्पिरेटरी रेट कसा कमी होतो, त्याच्यावरती त्याची डेप्थ असते. दॅट इज द ओनली डिफरन्स.
ओके.
जोगळेकर तुम्हाला
हॅलो, या ट्रान्सडेंटल मेडिटेशन बद्दल मी थोडं
क्वेश्चन आन्सर चालू आहे.
पुष्पाने विचारलं होतं ना, त्याच्याबद्दल मी सांगते.
अन्विता जोगळेकर सांगतात.
हा, पुष्पा तू जे विचारलं होतंस ते मी थोडस त्याच्याबद्दल वाचलं होतं. त्याच्यामध्ये फरक एवढाच होता की ते तुम्हाला म्हणजे ऍसेस करतात आणि तुम्हाला म्हणे एक मंत्र देतात आणि त्या मंत्राने तुम्ही ते मेडिटेशन करायचं असतं. पण त्या मंत्रामुळे असा फरक पडेल असं मला वाटत नाही. आता मालू सांगू शकते त्याच्यामुळे फरक पडेल का, पण ऍक्च्युली तुम्ही कसं मेडिटेशन करता त्याच्यावर जास्ती अवलंबून असतं.
तू म्हणते ते बरोबर आहे. ते मंत्र म्हणजे काय, आपल्याकडे जसं आपण जप करतो, ओके, त्याचाच तो अर्थ आहे. आणि इथे म्हणजे वेस्टर्न कंट्रीज मध्ये जपच्या ऐवजी तो ठराविक एक तुम्हाला जो मंत्र दिलेला असतो त्याच्यावरती तुम्ही कॉन्सन्ट्रेशन करता आणि तो जप सारखा म्हणत राहता. मी पण त्याचा कोर्स केलेला होता, परंतु इव्हेंच्युअली तुम्हाला इफेक्ट काय पाहिजे आहे की तुमचा हार्ट रेट कमी झाला पाहिजे आणि तुमचं कॉन्सन्ट्रेशन, इनवर्ड कॉन्सन्ट्रेशन वाढलं पाहिजे त्याच्यातनं. वेन यू गो इन टू द मेडिकेशन यू फॉरगेट अबाउट ऑल द सराउंडिंग्स. किंवा आपले कधी कधी जर बॉडी तुमची पेन वगैरे असेल तर तुम्ही तेवढ्या डेप्थला जाऊ शकत नाही, कारण आपलं माइंड त्याच्यामध्ये ऑक्युपाईड असतं की मला सरळ बसता येत नाही किंवा मला पाय दुखतो आहे, मांडी घालता येत नाही. हे ज्या वेळेला विचार येतात त्यावेळेला तुम्ही त्या डेप्थ मध्ये जाऊ शकत नाही. तर द मेन थिंग इज मेक युअर सेल्फ व्हेरी कम्फर्टेबल नो मॅटर व्हॉट कंडिशन यू आर सिटिंग अप ऑर लाईंग डाऊन. त्याच्यामुळे तुमचे लाईंग डाऊनचं सुद्धा ज्या वेळेला आपण शवासन करतो दॅट इज ऑल्सो व्हेरी इफेक्टिव्ह. इट इज लाईंग डाऊन मेडिटेशन. म्हणजे ट्रेडिशनली आपण सिटिंग डाऊन करतो, पण तुम्ही जर शवासनामध्ये गेलात इव्हेंच्युअली द इफेक्ट ऑफ इट इज टू ब्रिंग युअर blood pressure down, bring your heart rate down, your respiratory rate down, and it happens definitely.
Unfortunately ते शवासन करताना झोपच येते.
नाही नाही, त्याच्यामध्ये शवासन करताना तेवढं मात्र माइंड अलर्ट असलं पाहिजे. यू डोंट
नाव आहे शवासन, निदान झोप म्हणजे तरी बरं आहे.
दुर्गाताई यांचा हात वरती आहे, तर दुर्गाताई आणि नंतर मग कोण, मिसेस कुकडे.
येस,
मी
फक्त
मी पण आहे.
ओके,
हो,
मी फक्त एकच नाही, मगाशी मी एक शब्द वाचला म्हणजे मला हे अगदी हसू येण्यासारखं आहे, पण ब्रोकन हार्ट म्हणजे प्रेमभंग नाही ना, म्हणजे एवढंच मी विचारते, बाकी
प्रेमभंगाने पण ते होऊ शकतं.
ह्या वयाला, आता आपल्याला ह्या वयाला प्रेमभंगाचा धोका फार कमी संभवतो, त्यामुळे
नाही, आपल्याला सेपरेशन होऊ शकतं. सेपरेशन इज वन ऑफ द थिंग.
त्याच्या आधी प्रेमात पडलं पाहिजे. दुर्गा त्याच्या आधी प्रेमात पडलं पाहिजे.
हा, बरोबर आहे.
त्याशिवाय भंग होणार का?
असो.
सरिता, गो हेड.
हा, मला डॉक्टर वार्देकरांना एक छोटस प्रश्न आहे.
येस.
इन्स्टेड ऑफ कोकोनट ऑइल, खोबऱ्याचे हे चंक खाल्लं तर काय फरक पडतो?
The amount of fat will remain same. बेसिकली त्याच्यात काय आहे की द सॅच्युरेटेड फॅट त्याच्यात खूप जास्त आहेत आणि त्याच्यामुळे तुमचं LDL वाढायचे चान्सेस वाढतात, पण नॉट सिग्निफिकंट, बिकॉज आय ऑलरेडी टोल्ड यू दॅट डाएटचा इफेक्ट फार कमी आहे. म्हणजे पण टोटल काय आहे की तुम्हाला अमेरिकन न्यूट्रिशनल सोसायटी त्यांनी जर तुम्हाला म्हटलंय की 10-12 टोटल 13 ग्राम तुम्ही सॅच्युरेटेड फॅट दिवसातनं खा, तर त्याच्यात तुम्ही ती वडी खाल्ली, तुम्ही वडी फॉर्म मध्ये घ्या किंवा तुपाच्या वडी फॉर्म मध्ये नॅचरली देर इज ए न्यूट्रलायझिंग फॅक्टर, बिकॉज इन द फॉर्म ऑफ वडी देर इज सम फायबर ऑल्सो देअर, बिकॉज ते तुम्ही कोकोनटचा फायबर त्याच्या बरोबर घेता. सो इट विल हॅव लेस ॲब्सॉर्प्शन because the fiber will reduce the absorption. Compared to that, तुम्ही extracted oil, त्याचं ऑइल घेतलं किंवा तूप म्हणजे खोबरेल तेल घेतलं तर त्याच्यात there is nothing which is stopping it from getting absorbed. So that will be the only difference. The amount absorbed of the fat absorbed will be much less तुम्ही वडी खाल्ली compared to तुम्ही
तूप
किंवा खोबरं वापरलं
तुकडे खाल्ले तर
तेच की आहे.
थँक्यू.
आनंद मनोहर, तुम्हाला विचारायचं ना प्रश्न?
या मला एक क्वेश्चन म्हणजे तुम्ही मगाशी जे निरनिराळे 10 वेगवेगळे सांगितले की ज्याच्यामुळे परिणाम होतो चांगला, त्याच्यात तुम्ही एक CoQ10 सांगितलं होतं. ते CoQ10 काही सिम्पटम्स असले तरच घ्यायचं का नुसतं घेतलं तरी चालेल?
इट इज अन अँटीऑक्सिडंट, सो इट इज गिव्हन फॉर प्रिव्हेन्शन. म्हणजे तुमच्या एंडोथिलियम डॅमेज कधी ना कधी होतच असतो, कारण ब्लड आपला ऍक्टिव्हिटी वाढते, ब्लड फ्लो वाढतो, चा इफेक्ट होतो, ब्लड प्रेशर कधी कधी वाढतं, कधी कधी आपण एक्साइटेड होतो. तर ते एंडोथिलियल डॅमेज झालं की तिथे ते LDL चिकटलं तरी ते ऑक्सिडाइज होऊ नये, त्याच्यासाठी हे CoQ10 घेतात. आणि त्या रिझल्ट त्यांनी जे दाखवलेले आहेत CoQ10चे, की द नंबर ऑफ एपिसोड्स ऑफ कोरोनरी was comparatively reduced, and as I showed you, those people who had higher levels of CoQ10, डॅनिश आणि ह्याची जी स्टडी तुम्हाला सांगितली की त्यांना एकाला ग्रीनलँड वाल्यांना होत नाही आणि ह्याला होतं, आणि तसंच इंडियन लोकांना CoQ10 कमी असतं त्यांना होतं. म्हणजे इट हॅज गॉट सम प्रोटेक्टिव्ह इफेक्ट. सो दॅट इज द रिझन. इट इज नॉट गोइंग टू हार्म यू अँड इट मे प्रिव्हेंट LDL फ्रॉम गेटिंग ऑक्सिडाइज. म्हणून मी तुम्हाला ते संबंध मेकॅनिझमच समजवली होती, हाऊ इट मे बी वर्किंग, त्याचं तुम्हाला बॅकग्राऊंड दिलंय.
मग काही सिम्पटम नसले तरी घेतलं तरी चालेल म्हणजे?
इट्स अ प्रिव्हेंटिव्ह थिंग.
या
इट इज नॉट फॉर ट्रीटमेंट. इट इज नॉट अ ट्रीटमेंट. इट्स अ प्रिव्हेन्शन.
थँक्यू.
चित्रा कुलकर्णी.
डॉक्टर वार्डेकर, खूप छान सांगितलं तुम्ही, मला पण खूप आवडलं. तुम्ही सांगितलं की 3 कारणांनी ते एंडोथिलियल ब्रेक होऊ शकतात. पहिलं ते ब्लड प्रेशर, नंतर स्मोकिंग, आणि तिसरं तुम्ही सांगितलं की कॉरोनरी आर्टरी बायफर्गेट होते आणि त्या ब्लड फ्लोनी पण ते होतं. मग हे नॅचरल आहे, तर ते आपण कसं प्रिव्हेंट करू शकणार?
ते नाही प्रिव्हेंट करू शकत, पण त्या मी 3 फक्त लिहायला तिथे म्हणून जागा नव्हती म्हणून मी 3च लिहिले आहेत. पण ऑल दोज जे तुम्हाला मी हे सांगितलं रिस्क फॅक्टर्स, ऑल दोज रिस्क फॅक्टर्स कॅन प्रोड्यूस दॅट एंडोथिलियल डॅमेज. म्हणजे त्याच्यात स्ट्रेस आला म्हणजे तुमचं ब्लड प्रेशर ठीक होतं, तुमचा ब्लड फ्लो वाढतो. सो ऑल दीज फॅक्टर्स विच वी टॉक्ड अबाउट, the risk factors, all those risk factors can be provocative to produce endothelial damage. So मी तिथे लिहायला म्हणून एक्झाम्पल म्हणून ब्लड प्रेशर आणि LDL 2 वस्तू लिहिल्या होत्या आणि स्मोकिंग लिहिलं होतं. पण इफ यू रिमेंबर द फ्रमिंगम जे दिलं होतं, त्या ऑल दोज फॅक्टर्स कॅन ऍक्ट टू प्रोड्यूस एंडोथिलियल डॅमेज ओव्हर अ पिरियड ऑफ इयर्स. मी ते बायफर्केशन काय दाखवलं होतं की दॅट इज द एरिया विच इज मोर प्रोन. दॅट डझंट, म्हणजे तिथे ते बिकॉज जेट इफेक्ट आणि टर्ब्युलंट इफेक्ट जास्त होतो. म्हणून कोरोनरी आर्टरी जेव्हा अफेक्ट होते, नॉर्मली कुठलीही आर्टरी जी इफेक्ट होते ते बायफर्केशनच्या तिथे जास्त होते. इव्हन कॅरोटिड आर्टरी जेव्हा ब्लॉक होते तेव्हा ती बायफर्केशनच्या तिथे जास्त होते. त्याचं कारण तुम्हाला मी तिथे सांगितलं, कारण तिथे तो जेट जास्त मारतो, because there is a change in direction and the change in the lumen, because तिथे बायफर्केट करते ना, सो ल्युमेन खालती लहान झाला, सो त्याच्यामुळे तो स्पीड वाढल्यामुळे ते स्क्रॅची इफेक्ट त्याचा जास्त होणार. सो दॅट वी कॅनॉट चेंज. बायफर्केशन्स आर बायफर्केशन्स, but we can prevent the other factors, which is the
LDL and other stuff.
LDL, force of flow,
Smoking.
the pressure, the smoking, the obesity, the diabetes. So all these are endothelial damaging substances.
Okay, thank you very much. Thank you.
डॉक्टर वार्डेकर, तुम्ही मगाशी जे पल्स रेट बद्दल सांगितलं, मॅक्सिमम पल्स रेट वगैरे, तर त्यात थोडीशी मला तर हे करायची माहिती थोडीशी द्यायची होती. मी कॅनरा लाईफमध्ये काम करत असताना तरी खूप मोठा फिटनेस प्रोग्राम तिथे इन्कॉर्पोरेट केला होता. तर त्यावेळेला बरीचशी माहिती त्यांनी दिली होती. तर त्यावेळेला एक तरी सोपा फॉर्म्युला सांगितला होता की तुम्ही जेव्हा एक्सरसाइज करता तेव्हा तुमची जी ब्लड प्रेशरची पल्स रेटची रेंज आहे ते 170 मायनस एज,
220 मायनस एज आहे.
200 मायनस एच नाही 220 हे झालं पण त्याला ते मल्टिप्लिकेशन 75-80% हे करून की तुम्ही जेव्हा एक्सरसाइज करता तर तुमचा पल्स रेट 170 मायनस एच टू 200 मायनस एच ह्या रेंज मध्ये तुम्ही ठेवा ऍटलीस्ट फॉर 20 मिनिट्स. म्हणजे 200 मायनस एच म्हणजे एखाद्याचं वय जर 75 असेल तर 125च्या वर तुम्ही जाऊ देऊ नका बिकॉज देयर इज नो additional benefit for that and there could be some risk involved.
Exactly.
So this is the simple formula to remember 170 minus 8 to 200 minus 8.
That's a detail, the slides which I have not shown you. I have sent, there is a slide which gives you exact calculation. The rough calculation 220 minus 8 सांगितलं होतं. Exact calculation चं तुम्हाला ते table I have provided it in the additional slides. I did not have time to go over it, but it is already there. And त्याच्यात precise म्हणजे ते कार्डियाक रेट रिझर्व काढतात आणि एज काढतात सगळंच इंटू अकाउंट घेऊन मग ते त्याच्याने कॅल्क्युलेट करतात, विच इज अ मच मोर ॲक्युरेट मेथड. बट आय हॅव ऑलरेडी प्रोव्हाइडेड यू विथ दॅट स्लाइड.
Savita Junnarkar, you have question? Yeah, unmute yourself, please.
मला विचारायचं, आपण ऐकतो की हार्ट अटॅक फक्त सकाळी किंवा रात्री असे सकाळच्या वेळेस असे होतात. Is there a reason for that? Is it true?
Yes, circadian rhythm, because that is the time between 3 and 5. Very common to have strokes and heart attack during that morning hour, when there is a sudden surge of catecholamines and steroidal hormones, which to prepare us for the morning wake up, जागे होतात ते, and that produces a sudden increase in the pulse rate and the blood pressure in the early hours of the morning, and certain coagulation factors also. So all in all, the incidence, it is a known phenomenon that between 3 and 5, the incidence of heart attack and strokes are highest during that period of time, and it has something to do with the circadian rhythm and the secretion of sudden surge of hormones from different glands, including the growth hormone, adrenal hormone. So all these things are secreted in a high level between that frame of time, and incidence जास्त आहे, absolutely correct. That is an observation, and the reason given is, these are the reasons given.
So the fact that they say that if you drink a glass of water, if you get up at night or झोपायच्या वेळी, त्याचा काय उपयोग होत नाही ना?
I have been doing a lot of work on this, because this also creates a rise in the blood sugar in the morning. Lot of people, they have got high blood sugars in the morning when they get up in the morning. Not lot, but 20 to 30% people. I am one of them, which has that. So in these cases, the early morning rise, त्याला dawn phenomenon म्हणतात, DAWN, dawn phenomenon म्हणतात. त्याच्यामध्ये ब्लड शुगर सकाळी जास्त असतात, आणि ते कमी करायला there are 3 or 4 things which we suggest to do. Number one is we shift our eating time earlier. Instead of eating at 8 or 9, we start eating at 6:30 or 7. Secondly, we add 15 minutes of exercise. म्हणजे शतपावल्या जे म्हणतो ना, severe exercise नाही. Even walking for 10 minutes, 15 minutes after your food helps to bring down the dawn phenomenon. So it is an observed phenomenon. It is a documented phenomenon. I do have it myself. And third thing, a tablespoonful of vinegar, which I'm even taking that apple cider vinegar. So 1 tablespoonful of vinegar brings your sugar down in the morning. Whether all these 3 protect you from heart attack, I don't know. But it is a known phenomenon, and unfortunately for circadian rhythm, we cannot do much about it. That is the usual time where the incidence of coronary episodes or strokes are highest, and it is related to circadian rhythm.
Thank you.
मला कोणाचे हात आता दिसत नाहीयेत वरती.
ओके, तर आपण आपल्याला प्रेझेंटेशन खूप चांगलं झालेलं आहे. तर आय विल इन्व्हाइट सविता धुंदरकर to give a vote of thanks to our speaker. Savita.
Good evening, Samarka. Our topic today, heart health, is extremely relevant for the senior membership we have today. And as we've aged, we've all tried to learn a little bit more about heart health, little snippets of information. Today, however, Dr. Wardekar has given us a well thought out, organized, thorough, and up-to-date talk on the topic of the day, heart health. He's given us much to digest and think about, how to make changes to our lifestyle, and even more importantly, the ability to recognize the moment immediate action needs to be taken. The why and how is of critical importance. For all this, on behalf of our membership and our executive committee, a heartfelt thank you to Dr. Wardekar. You were so good. In fact, you were so good that we will be now looking for subjects on which we can approach you to talk for the next time and to educate us further. So again, thank you very much. We really enjoyed the talk, and it was presented in a simple manner so that we could all really understand it and relate to it. Thank you.
Thank you.
ओके मंडळी, आता आपला प्रोग्राम संपत आलाय. फक्त 2 गोष्टी मी सांगणार आहे. पहिली गोष्ट म्हणजे आजचा जो आपला कार्यक्रम झालेला आहे त्याचं रेकॉर्डिंग मंडळाच्या YouTube चॅनलवरती टाकलं जाईल 1-2 दिवसामध्ये. तर ते टाकलं गेल्यानंतर त्याची लिंक मी तुम्हाला सगळ्या लोकांना पाठवेन. मी तुम्हाला जर ते बघायचं असेल किंवा परत जर काही ऐकायचं असेल कोण काय बोललं तर तुम्ही ते बघू शकता, किंवा तुम्ही तुमच्या कुणा मित्रमंडळींना पण ती लिंक तुम्ही पाठवू शकता. आणि आज ज्या स्लाइड्स दिलेल्या आहेत त्याची PDF कॉपी मी माझ्या गुगल ड्राईव्हवर टाकीन आणि त्याची लिंक पण मी तुम्हाला पाठवेन. मी तुम्हाला 2 लिंक्स पाठवेन. एक म्हणजे मंडळाच्या YouTube चॅनलवरती जे रेकॉर्डिंग आहे त्याची, आणि दुसरी लिंक असेल गुगल ड्राईव्हवर. हे ज्या सगळ्या स्लाइड्स आहेत 60 ते 70, त्याच्यामध्ये सगळी माहिती तुम्ही तुमच्या कम्प्युटरवरती डाउनलोड करू शकता. म्हणजे मग तुम्हाला काही जर बघायचं झालं तर आपण प्रत्यक्ष ऐकल्यानंतर सगळं काही लक्षात राहत नाही, पण ती सगळ्या स्लाइड्स तुम्ही तुमच्या कम्प्युटरवरती डाउनलोड करू शकता. आणि आपला पुढचा कार्यक्रम पुढच्या महिन्यात डिसेंबर, आता ख्रिसमसचा महिना आहे तर फार उशिरा न ठेवता 12 तारखेला प्लॅन केलेला आहे. आणि त्यावेळेला एक वेगळा विषय आहे. आतापर्यंत जे आपले कार्यक्रम झाले त्याच्यामध्ये आपली फक्त बघायची भूमिका होती, बोलत पण काही नव्हतं. तर पुढचा जो कार्यक्रमाचा विषय आहे की त्याच्यामधला एक विषय आहे की आपल्याचपैकी एकाने तो सुचवला होता, अजित कुकडेने, की माझ्या आयुष्यातील संस्मरणीय क्षण, कुठले इव्हेंट ज्यांना कोणाला नावं द्यायची असतील ती मी तुम्हाला सगळी माहिती आता लगेच थोड्या दिवसात पाठवीनच, की ज्यांना सांगायचं असेल की प्रत्येकाच्या आयुष्यामध्ये काहीतरी अशी क्षण येऊन जातात की ते तुमच्या जन्मभर लक्षात राहतात. तर अशा याच्याबद्दल तुम्हाला जर काही बोलायचं असेल तर मोर द मेरियर. तर ती सगळी माहिती मी तुम्हाला 1 आठवड्याभरात तुम्हाला पाठवीन. आणि त्याचं कोऑर्डिनेशन आपल्या मीना दातेकर करणार आहेत. तर त्यांच्याकडे मग त्यांनी नाव दिली की मग प्रत्येक वक्त्याला किती वेळ देता येईल हे नंतर मग कळवता येईल. पण त्या कार्यक्रमाची माहिती मी तुम्हाला लवकर कळवीनच. तर डॉक्टर वार्देकरांना माझे पर्सनल थँक्स. कार्यक्रम अतिशय चांगला झालेला आहे. आणि सविताने सांगितल्याप्रमाणे की असे आम्ही जास्तीत जास्त कार्यक्रम ठेवायचा प्रयत्न करू. मी तुमच्या थ्रू तुमच्या जी काही तुमचं ज्ञानाचं भांडार आहे ते आमच्यापर्यंत तुम्ही पोहोचवायला त्याची नक्की मदत होईल. थँक्स व्हेरी मच.
Excellent presentation, Dr. Wardekar.
Thank you.
Dr. Wardekar, excellent presentation. We really enjoyed very thoroughly. You express it very nice. Thank you.
Thank you. It was a little too technical, but I wanted you to get the very. And that is the reason I am providing you with all the slides. कारण हे बऱ्याचशा त्याच्यात रेफरन्स स्लाइड्स आहेत, सो दॅट यू कॅन रिफर टू इट. ते कलेक्टेड इन्फॉर्मेशन आहे, ते तुम्हाला हुडकायला खूप वेळ लागतो. ते सगळं ऑलरेडी मी मेहनत करून हुडकून काढलेले आहे, एका ठिकाणी आहे. सो इट विल हेल्प यू टू गो अँड रिफर. काय प्रश्न आला की अरे LDL बद्दल काय आहे, ते जाऊन तुम्हाला ते बघता येईल.
एक प्रश्न विचारू का डॉक्टर वाटेकर?
शुअर
तुम्ही म्हणलात की तुम्ही एक चमचा व्हिनेगर खाता, ते केव्हा खाता? जेवणाबरोबर खाता का एनी टाइम?
म्हणजे डायबिटीज साठी जर म्हटलं तर ते म्हणतात की इमिजिएटली आफ्टर फूड. आणि मी जे खातो ते मॉर्निंग हायपरग्लायसेमियासाठी खातो.
No, I know. That's what I have the same problem. So
a lot of people have that. The morning hyperglycemia.
जेवण झाल्याबरोबर तुमचा चमचाभर व्हिनेगर घेता का?
चमचाभर व्हिनेगर, मी ते ऍपल सायडर व्हिनेगर आणलंय.
ओके.
ऍपल सायडर व्हिनेगर कंपॅरेटिव्हली त्याला डायल्यूट करून ते पिणं सोपं पडतं, कारण इट इज प्रिटी पंजेंट. टू ड्रिंक व्हिनेगर इज नॉट व्हेरी इझी. आणि त्यांनी ते म्हणतात की इन देयर इज अ स्टडी. If you need the reference, I can send you the study. There is a definite study which has shown that the morning blood sugar started dropping by in about 3 weeks' time after taking apple cider vinegar, 1 tablespoonful of apple cider vinegar.
म्हणजे रात्री जेवणानंतर घ्यायचं का ते?
हो, रात्री मी लेट घेतो. म्हणजे मी जेवण 6:30ला शिफ्ट केलेलं आहे. तो 6:30ला जेवतो आणि मग मी 9-9:30
झोपायच्या आधी
तेव्हा घेतो.
अच्छा. तसं व्हिनेगरचा चांगला फायदा म्हणून ते पोटॅटो सॅलड विषयी म्हणतात. पोटॅटो सॅलड मध्ये व्हिनेगर घातलं तर त्याचा फॅटनेसचा इफेक्ट कमी होतो.
It cuts basically it reduces the absorption. It reduces the absorption of sugar and it reduces the absorption of fat. And म्हणून lot of people say that immediately after food, if you take that vinegar, the absorption तुमचं जे कार्बोहायड्रेटचं होतं ते रिड्यूस होतं.
राईट.
बेसिकली.
थँक्यू.
मी एक प्रश्न विचारू का?
रजनी. ओके.
आता जेवणाची वेळ झाली आहे म्हणून विचारते की कच्चा गार्लिक खाल्लेला चांगला नाही, म्हणजे चांगला
लसणाची चटणी
आणि कच्चा लसूण खायचा. पण आपण भरपूर लसूण घालून फोडणी दिली वरणाला तर त्याचा पण भरपूर घालायचा लसूण आणि वरणाला फोडणी द्यायची.
त्याच्यात काय होतं की जे ऍक्टिव्ह इन्ग्रेडियंट आहे ना ते 60 डिग्रीच्या वरती ते इनॅक्टिव्ह होऊन जातं.
राईट.
सो यू
लसणाची चटणी करून
किती म्हणजे डिपेंड्स अपॉन हाऊ मच हीट. पण जर फोडणी आपण केली तर त्याच्यात उकळत्या तेलातच घालणार ते.
बरोबर.
आणि म्हणजे ते 60 डिग्री सेल्सिअसच्या वरती ते डिनेचर होतं. म्हणजे दॅट इफेक्टिव्हनेस विल नॉट रिमेन
गार्लिकच्या
बद्दल तिखट करा.
मी तुम्हाला डेटा ड्रिव्हन दिलं, म्हणजे डेटा दिला की हाऊ इट वर्क्स अँड वेअर इट वर्क्स अँड हाऊ मच इट वर्क्स.
ओके. जस्ट अ क्विक क्वेश्चन ऑन ब्लड प्रेशर. पुष्कळ लोक मीठ कमी करतात. आपण तेवढं
there was a section which I was going to cover on the salt, which I eliminated because of the time factor. नॉर्मल ते म्हणतात की ते नॉर्मल अमेरिकन डाएट रेकमेंडेशन आहे की ज्याला हायपरटेन्शन नाही आहे त्यांनी 2300 मिलीग्राम 2300 मिलीग्राम सॉल्ट दिवसभरात घ्या. आणि ज्या लोकांना आहे हायपरटेन्शन त्यांनी ते 1500च्या खालती आणा.
सो पण पुष्कळ आपल्या ह्याच्यात आता पुष्कळ आपण ऐकलंय दे हॅव इन्सिडेन्सेस ऑफ लो सोडियम. सो फार पण कमी केलेलं बरं नाही ना?
Depends upon if you have got problem with hyponatremia. Majority of hyponatremia म्हणजे which is called as low sodium levels. खूप लोकांना म्हणजे इंडियामध्ये तर इट इज सो कॉमन and particularly elderly लोकांना. Most of it is related to either a defective hydration, म्हणजे त्यांच्या खाण्यातच टोटल कमी जसं सो and excessive sweating. So if those people who have, आणि इंडियामध्ये तो जास्त कॉमन प्रॉब्लेम होतो because there is
heat and there is increased sweating and there is a lot of salt is lost in the sweat, and if it is not properly replaced, elderly लोकांमध्ये hyponatremia is very common. हायपोनॅट्रेमिया हा कम्प्लीट एक मोठा सब्जेक्टच आहे, म्हणजे त्याचे हजारो कॉजेस आहेत हायपोनॅट्रेमियाचे.
मग ते बरंच आता मी म्हणत होते की ना तुम्हाला दुसऱ्या कुठच्या तरी टॉपिक वरती बोलायला सांगितलं पाहिजे.
हायपोनॅट्रेमिया हा प्रचंड मोठा सब्जेक्ट आहे आणि तो म्हणजे someday if and when I talk about hypertension, probably I can approach the hyponatremia at the same time.
Okay. Thank you.
परत एकदा लेक्चर देऊ शकाल का तुम्ही?
मी स्टेपनी आहे, मी ह्या लोकांना जरूरत पडली तर बोलतो. मी स्टेपनी टायर इज डिझायरेबल व्हेन इट इज नीडेड.
इथे तर त्यांनी लिमिट वाढवली सोडियमची चक्क मध्ये.
आमच्या फोरमच्या लिस्ट वरती हायपरटेन्शन आणि स्ट्रोक हे 2 विषय वार्देकरांनी सांगितलेले आहेत, तर ते पुढच्या वर्षी केव्हा तरी आपण घेणार.
दॅट विल बी नाईस. गुड. चला.
So I think we had enough discussion. So can I close the meeting?
Yes, thank you all. Thank you
so much. Thank you very much.
Thank you.
Bye. काळजी घ्या.
Bye. Bye.